Hi, Doctors of Inala. Welcome to my propaganda piece on opioid agonist therapy. This presentation is bespoke for you all, so you all know who I am. It's still 2023, but only just. So remember that in 2024, you'll be eagerly looking to complete your 50 hours of CPD. I'll bring this up for no particular reason. So we need to create a burning platform. Why am I asking you to pay attention to this issue? There is an overdose death every 4 hours in Australia. Opioids are responsible for almost half of these, and then benzodiazepines are responsible for almost a third. 3/4 are unintentional. It is the third leading cause of death among young men and women. Think of the devastation inherent in these numbers. Much higher for Aboriginal and Torres Strait Islander people at 20 per 10,000, which is higher than the death rate from road traffic accidents. This all came to a head in this community in 2015 when a patient who was actually a regular of mine came out of prison and went pretty much straight to ATODs across the road looking to get on the Suboxone program. They were called ATODs back then. He also came to the Inala COE the same day and saw one of our GPs. Inala ATODs put him on a waiting list and he left untreated. He died of an unintentional overdose 2 days later from heroin. This devastation came on the background of multiple devastations in the community and unsatisfactory interactions with the Alcohol and Drug Service, in amongst some satisfactory ones, and a report was commissioned. It was published in 2016, and the executive summary reads, "Drug and alcohol use is a major area of concern for the Aboriginal and Torres Strait Islander population of Inala and surrounding areas. This consultation came about primarily because of the fatal overdose of an Aboriginal man who was recently released from prison and sought help for opiate addiction from the Inala AODs. He was unable to get into a treatment program, however he was referred to another service which he failed to attend. Following this, he overdosed and died. Community members subsequently called for action on this issue. Recommendations from the community included that we should explore opportunities for the COE staff to treat drug and alcohol patients, which would include prescribing Suboxone and methadone, and to learn from the success stories of Suboxone treatment at the Medico Centre at Inala." And the last one irked me a bit because it was a privately billing service over the road that was clearly providing a better service in this space for opioid replacement therapy and hepatitis C treatment than we were for our patients, and it seemed like something we really needed to address. So what do we have to do? To prescribe buprenorphine, you only need to do 2 self-paced modules. That's it. If you want to prescribe Subutex, which is buprenorphine by itself in a tablet form, and methadone, then you have to do an extra module and sit in with an AOD surface for a day. I would say to you that this is totally unnecessary for our needs at the Inala COE. When Warren and I did the training, we had to do all of it, so we are level 1 prescribers. But being able to plausibly deny people methadone and Subutex would be a big plus, and just stick to the very safe buprenorphine naloxone films or the long-acting injectables. So level 1, 2 self-paced modules, that's it. So what are we actually treating? The condition is opioid dependence, which is a chronic relapsing condition with periods of active use, abstinence and relapse over years, and we have to be prepared to go on a journey. There are checklists which in summary contain items like taking more opiates than intended, getting cravings, failing to fulfill major roles in your life, giving up social and occupational recreational activities for drugs, having obvious physical tolerance, and also withdrawal. And this condition actually has a really poor prognosis, as we've discussed. There is a high risk of overdose death and huge societal costs. They calculated it in the US one year, and it was $1 trillion. I think that was 2017. So a bit of a slide on pharmacology. Methadone is basically just a long-acting proper opiate which clings fairly tightly to receptors and will block other opiates at doses over 60 milligrams. It has the usual opiate side effects including withdrawal, and it can kill people. So there were 200 deaths in 2021 alone. I have 2 patients on methadone, and one of them has already been taken to hospital unconscious after a semi-intentional overdose. Buprenorphine, on the other hand, has some amazing pharmacological properties. It grabs all the opiate receptors really tightly, gives them a little push, it's a partial agonist, so you do get an effect 30 minutes after taking it, but it then stops cravings, blocks all other opiates, and in fact grabs the receptors so hard it will precipitate withdrawal if you have any opiates on board. It can actually be used as a reversal agent in an emergency, a bit like naloxone. The long-acting injectables have a pretty awesome withdrawal profile because they just slowly reduce in your system, so it's probably one of the easiest ways to come off, and I often have people coming back only 6 weeks later when they realise it's all gone from their system. It's actually really hard to die from buprenorphine. You pretty much have to give it to yourself intravenously and take benzos at the same time. There have been 314 deaths attributable to buprenorphine alone or primarily in the last 19 years. It's okay in pregnancy. We don't know about breastfeeding. There's not the data. We can give buprenorphine alone if it is a depot subcutaneous injection, or we combine it with naloxone in a sublingual film, which makes it much less enjoyable to inject because the naloxone will put you into withdrawal. So it is still diverted as a film, but it doesn't tend to get injected. Untreated opioid dependence is a lethal condition. So when you're off treatment, the mortality is 2.5 times the rate of being on treatment, and the overdose mortality is 8 times. Buprenorphine should really be in the water supply. In meta-analyses, it's been shown to improve mental health, quality of life, chronic non-cancer pain, which means you can change people dependent on prescription opiates to buprenorphine and truthfully tell them that the buprenorphine is still going to help their pain. You probably wouldn't start buprenorphine for chronic non-cancer pain, though obviously we do put people on buprenorphine patches. Being on the long-acting buprenorphine improves employment chances and has been shown to reduce ED visits and days in hospital. And the long-acting injectable is probably better at these things than Suboxone, including getting people off opiates altogether, so they've got a urine-confirmed opiate negative. So how come all doctors aren't diving into this? Why isn't it in the water supply? I guess the main reason is stigma. We just don't like or trust this group, which was something poignantly spoken out loud in one qualitative study. They don't like us. We worry that it'll take over our professional lives and we'll be swamped with difficult and demanding patients that'll cause us untold pain and burnout. We've only just emerged from COVID. The last thing we need is another really difficult challenge. As a result of this stigma, I would argue that there are lots of rules and red tape to get our heads around that are probably unnecessary. And, you know, we don't know much about these drugs and we're already busy. So there's some of the barriers. But I would argue that we're seeing these patients anyway. We work in an Aboriginal and Torres Strait Islander health service after all. Warren and I are busy, but not totally overwhelmed, and more prescribers can only make this easier. Imagine if we all prescribed and just treated our own patients who we saw anyway. That would be so much better. And it gives you a very effective tool to manage your already complex patients. They're also very safe drugs, especially buprenorphine. Don't be put off by the stupid amounts of regulation, which are a hangover of stigma and a war on drugs type of mentality. How does this all work in practice? Patients usually present out of the blue the first time and often at inopportune times, but I generally like to strike while the iron is hot, especially if they are newly out of prison. We need to treat those patients like a primary care emergency. I start by asking about their alcohol and other drugs history. I do the regulatory requirements of height, weight, urine drug screen, and take the photo, which sometimes I forget because it feels a bit too much like a mugshot. And feeds into some sort of stigma prison mentality. I do the program starting form and their consent to be on the program form. I consider hepatitis C and provide everyone with a Nixoid script, which is naloxone up the nose. And I sell it as saving a relative's life maybe, or everyone should have it in their pocket, or could be their own life. They might not have to call the police if they can resuscitate someone themselves or go to hospital. We then have a discussion about whether they would prefer Suboxone films or the long-acting injectable buprenorphine, and that's usually enough for the first, usually unplanned but not always, first visit. Then at the next visit, I'll consider a GP mental health care plan, social supports, preventative health, so 715 GPMP, possibly review their bloods and start hepatitis C treatment, adjust their dose depending on cravings or opioid use if they're on the underdosing side of things, and reduce their dose if they've got sedation, like they're a bit overdosed. The maintenance visits for people in the program, once all of this has been sorted out, can be very straightforward and rewarding. So they're often doing really well. They're often quite brief. Once they're on a stable dose, it literally can just be a check-in and just a script. So I've got a few inspiring success stories to share with you. The first, and still one of the most notable for me, was Ms. CK, one of my first patients, who was very chaotic, had severe mental illness, psychosis, caused her family and no doubt herself no end of grief. On the program, she held down a job at times, and then she got into rehab in Toowoomba, and she's been there for, gosh, it's about 12 months now, and is off everything. When her family members come into clinic, they pull me aside in clinic to give me happy updates. Ms. RB has been a regular of mine for quite a few years now, and when I say regular, sometimes just about every day. Like, I would come into work kind of dreading that she would be on the phone. She has a heady mix of borderline personality, psychosis, some violent episodes, and severe compulsive drug addiction. And she's still not perfect, but gosh, now I talk to her every couple of weeks. She's on monthly long-acting injection at the Slacks Creek chemist where she gets the injections. She's off all tablets, including endone and benzodiazepines that she used to be on, and the change has just been miraculous. And the others are similarly amazing. So in conclusion, the community desperately want us to do the best we can to combat drug addiction. Buprenorphine for opioid dependence has amazing pharmacological properties, is very safe, and saves lives. We're seeing these patients anyway. Warren and I may want to go on holiday at the same time, sometime, or a conference together. Please do the training. It's very straightforward. Thank you everyone for getting this far. The next few slides just include some of the references for the studies I presented.